Good evening, everybody. So today we're going to talk about personality disorders. Now, I don't want you to start naming people out loud, but you can think of who may come to mind, and you may see some of these on your favorite TV shows because these can be very entertaining to watch. We don't diagnose people from television. These are fairly common, but I will say what constitutes a disorder is very specific. So people may do irritating things or things you don't understand. That doesn't make it a disorder. When most people hear personality disorder, they tend to think difficult patient. And I want you to shift that today. What I want you to think about when you hear personality disorder is picture some patients, and I'll give you some hypotheticals, and then we'll work with them as we go through this. But so Leah is a 26-year-old woman who alternates between "I love you" and then threatening to sue you. Marcus is a 35-year-old guy who's charming everybody but never follows through. Anna is a 42-year-old who brings a color-coded binder to every visit and sits to take notes and still feels like a failure. And these are not bad patients. These are nervous systems and relationship templates that were shaped long before they ever met you in the therapy session. And our job is going to be to understand the story behind their patterns of and work with, not against, the way they're wired. So that's what I want you to think about when we go through personality disorders. So by the end of this session, I want you to be able to do four things. First, I want you to be able to explain to a layperson, and you can use this as a means of studying for your exam, explain to a layperson what personality and ego actually are. First in clinical language, and then explain it so that they will understand it. The reason you want to get good at this is because when you give this diagnosis of personality disorder, you are going to have to tell it to your patients and find a way to explain it to them. This is not like a secret diagnosis that you label them with and don't tell them. You need to be able to tell them. I think you might have borderline personality disorder. And you might have to say that and realize we're going to work on something. The other thing I want you to be able to do is to link personality disorders to early development. So if Erickson was not your friend, he's going to become your friend now again because it underpins a lot of what we do. And I also want you to understand this concept of object relations, not as something to know for Jeopardy trivia, but as a clinical map as to how you are going to understand your patient. And then the third thing I want you to do is to use that formulation framework we talk about every week in regards to predisposing, precipitating, perpetuating, and protective factors as you go through this. And think beyond this person's just borderline or he's just a narcissist. You need to go a little beyond that. And then finally, we're going to wrap up with distinguishing between cluster A, cluster B, and cluster C in some real world presentations. And we'll look at things that often get confused, like borderline personality disorder with bipolar disorder, or OCD versus OCPD, or schizotypal personality disorder versus schizophrenia. So today we're just going to learn this operating system that's underneath the behaviors that tend to frustrate clinicians the most. Okay. Now, before we talk about personality disorders, we have to talk about personality itself. This is the baseline operating system that every human being runs on. So, the first thing we need to talk about are personality traits. These personality traits are the recurring patterns, ways of thinking, feeling, relating, behaving, and these show up across time and across situations. Think of traits as your psychological default setting. Some people will enter a room scanning for danger. Others scan for connection. Some walk in leading with warmth. Others walk in and try to figure out how I can control everything. These patterns are not random. They're shaped by temperament, development, attachment, and the stories we internalize about who we are. Pay close attention to that phrase. The stories we internalize about who we are. The other thing we need to do is distinguish personality traits. So a trait becomes clinically meaningful when it's consistent across contexts and it's predictable over time. And it has to be stable into adulthood. And that's important because you don't want to go labeling adolescents with personality disorders just yet because it's still forming. It's not quite solidified, although we'll talk about some of these early theories and you can say, well, maybe it's a budding personality disorder, but we tend to reserve judgment on labeling that if it's too early in the psychological development. So, what's a trait? So, for example, being very meticulous is a trait. My wife needing the dishwasher loaded her way, that's a trait. Double checking the door is locked, that's a trait. These are quirks, tendencies, familiar rhythms. Traits are not pathology, though. Traits only become problems when they harden into patterns that limit flexibility and restrict function. Remember, I told you early on one of the tells of mental illness is rigidity? Here's a tell for you. So if the flexibility is so limited and they can't possibly entertain another concept, that's a sign of being mentally unwell. Now, what's a personality disorder then if all of these irritating things are traits only? Well, what makes it a disorder? Well, the disorder is not about drama or difficult behavior. A disorder has to be a pervasive and inflexible pattern, a way of navigating the world that might have once been adaptive. It worked for them, but now it's causing distress, dysfunction, and instability in the relationships. Or it impairs work and identity. In other words, they're not fulfilling their roles. So if a personality trait, these are the settings. A disorder is when the settings get stuck. If the traits are the settings, it becomes a disorder when the trait gets stuck. So when the person can't adjust, when the person can't pivot, when they can't relate differently, even when life demands it. And the key distinction that you need to pay attention to in a clinical setting is that traits are descriptors. Personality disorders are impairing. So you're going to focus on the level of impairment in order to say disorder. Traits add color to someone's individuality. Oh, that's just John. He likes to be very fastidious about whatever it is, you know. So personality disorders have to interfere with safety, stability, connection, functioning. It's the difference between she's cautious versus she's so terrified of rejection that she avoids all social contact. He likes being independent versus he breaks every meaningful relationship because intimacy feels like annihilation. So the impact, not the behavior alone, is what makes something a disorder. So some other words we need to get familiar with is ego. Now, when we say ego in psychiatry, we don't mean arrogant and self-important. What we mean here is ego is the mind's air traffic controller. This system that keeps impulses, reality, and identity from colliding into each other. And there's another phrase, egosyntonic. This means the person says, this feels like me about whatever thoughts, feelings, or behaviors they're having because it aligns with their self-image. They feel natural, justified, correct. This is why a lot of personality disorders are notoriously hard to treat. The perfectionist with OCPD doesn't say, my standards are ruining my life, right? The narcissistic patient doesn't say, my entitlement harms relationships. The antisocial patient doesn't say, my lack of remorse is a problem. They're egosyntonic. The problem is you, it's not me. It's egosyntonic. The behavior may be destructive, but it feels right to them. It fits their internal story of who they are. Conversely, ego dystonic means this does not feel like me. The patient experiences the thought or the behavior as intrusive, distressing, or unwanted. An OCD patient typically hates their obsessions. Many anxiety and depressive symptoms are ego dystonic. Even some borderline features can be ego dystonic, like the self-harm may deeply be shame-inducing. Ego dystonic says, I know something is wrong and I want it to stop. The distinction matters because ego dystonic conditions will typically produce insight and motivation for treatment and therapeutic engagement, whereas ego syntonic ones rarely do. I don't have a problem, they do. Now, there are four functional domains I want you to pay attention to with respect to personality disorders. I'll tell you what they are and then I'll tell you more about them. But cognition, affectivity, interpersonal functioning, and impulse control. So the first one you need to pay attention to is cognition. Cognition is how they perceive self, others, and the world. And this includes the distorted beliefs and the rigid worldviews and the paranoid or magical thinking. For example, paranoid personality disorder may say, oh, everyone's out to get me. Narcissistic personality disorder may say something like, I'm exceptional and deserve special treatment. Borderline personality might say something like, if someone pulls away, it means I'm worthless. The mind basically becomes an echo chamber of old injuries. Now, affectivity, the second domain, this discusses range, intensity, and lability of emotion. This is telling how do they feel, how intensely do they feel it, and how fast does it shift. This is especially noticeable in borderline personality disorder, where there's rapid emotional storms, or schizoid personality disorder, where they are just constricted and detached, or say histrionic personality disorder, where they're exaggerated and theatrically affected. That's like affect is the emotional thermostat. It's either broken or hypersensitive. The third domain was this interpersonal functioning. And this gets at the issue of capacity for empathy, closeness, and reciprocity. This is where most suffering happens. So antisocial personality disorder, say, would have a lack of remorse or relational responsibility. A dependent personality disorder, they cling desperately for reassurance. Someone say avoidant personality disorder, they want connection, but it's frozen by shame. These patterns aren't about being difficult. They see these as their survival strategies shaped by past trauma, neglect, or a rigid family system. Now, the fourth domain of personality, if you will, the fourth predisposing factor or the fourth manifestation would be something like, here is where you see things like impulse control, the ability to resist urges and tolerate distress. So distress intolerance is a major trigger for a lot of what we call acting out. So here you get to see the consequences of the emotional dysregulation. So this is where the impulse control is limited in someone with borderline because they give into the self-harm, substance abuse, or reckless decisions. Or in somebody with OCPD, the opposite. They have rigid over control that becomes its own impairment. Antisocial personality disorder, things like aggression and risk-taking, chronic disregard for consequences. Impulse control tells you how a patient copes when their internal world has become unbearable. So, ego shapes the story people tell about themselves, and personality disorders take that story and carve it into stone. Okay. So, to understand personality disorders, we have to understand the story of early development, not like as an abstract theory, but as a framework or an architecture for the self. Now, again, these are theories of personality. Now, there is a Western United States European bend to psychiatry, and that's what I'm presenting to you because that's how the DSM is basically formulated. So these theories are very Western Euro UK centric. Just keep that in mind. It's one of the critiques of these of the psychiatric formulation. So there's a theory called the psychodynamic theory object relations, and this is basically we become who we are based on the relationships that shaped us. Okay? Not like in some sort of poetic metaphorical way, but the theory is that this has made a neurological and developmental pathway imprint, and our first caregivers become our first objects, meaning our first mental representation of safety, danger, love, rejection, and what it means to be held emotionally. So those early patterns are internalized and they become the blueprint for how we interpret every other relationship throughout life. And so that's unique because Freud would say this is all based on psychosexual stages of oral, anal, phallic, latency, and genital. But that language is outdated and we don't say that anymore, but we still take those principles in terms of stage-based crucial moments. So if the developmental need of the stage is not met, then the child adapts, right? Because they're trying to survive. However, the problem is that adaptation can become habitual and a lifelong pattern. So, for example, a child whose early environment is inconsistent learns to cling or push away. A child who is shamed for independence learns to fear autonomy. Okay, which theorist talked about autonomy versus shame and doubt? A child whose needs are ignored learns to suppress the need entirely. So that's the trust versus mistrust when they cry to make their needs known. So those patterns may have helped the child survive, but in adulthood, these can become the raw materials of what we are now calling personality disorders. Now, there was a Dr. Margaret Mahler. She was a Hungarian-born psychiatrist, psychoanalyst, very popular at the time, psychoanalysis. And she did most of her work in the mid-20th century. Why does that matter? Because in the mid-20th century, we were in the shadow of World War II and the Holocaust. And she trained in a world where children were often viewed as extensions of the family, not as individuals with their own psychological life. So this woman, she was a Jewish physician actually who fled anti-Semitism in Europe in the early war, post-war era, and she settled in the United States. And she, from a very early age, probably had some personal influences about what it meant to be separated from one's origins and forced to rebuild a life. So keep that backdrop in mind when we consider her theories. So, in the spotlight of post-war dislocated climate, there are effects of deprivation, obviously, child deprivation. Her focus was on the mother-child relationship. And that's radical because when she watched how toddlers moved from fusion with their caregiver to a separate, stable sense of me. So Mahler introduced this concept of separation individuation theory, and she mapped it on a journey from undifferentiated fusion, that is the early few months of life, to practicing independence, to the push-pull of reapproachment, and to object constancy. Now, I'll tell you more about that in a minute, but where the child can hold object constancy means that the child can hold a stable image of a loving caregiver even when they're physically absent. So, in a world that just witnessed mass displacement, shattered families, Mahler was essentially asking, what happens to a person's inner world when secure attachment is broken or never fully formed? And so that's the question that now sits at the heart of how we will understand personality disorders going forward from that time to now. It's still the zeitgeist of psychiatry. So the question also now is, how do disruptions lead to personality disorders? And this is a leap, because remember, all these are theories. This is her own observations. If a child never develops object constancy, the adult cannot tolerate distance, uncertainty, or mixed emotions. Now, think about some adults you've encountered that cannot tolerate distance, uncertainty, or mixed emotions. That's the emotional engine behind things like borderline personality disorder, right? That's fear of abandonment, splitting, rapid shifts, narcissistic personality disorder, very fragile self-esteem, dependent on admiration, avoidant personality disorder, overwhelming shame and fear of rejection, dependent personality disorder, terror of functioning independently. So it's not that these patients are dramatic or difficult, they're just living with the emotional capacities of a child who never finished building that internal scaffolding needed for stability. So when you see a personality disorder, you're not simply seeing bad behavior. What you're seeing is a developmental story that's kind of frozen in place. So we would call that like a latency. Okay. So if Mahler gives us this roadmap of separation, object relations shows us that architecture of the inner world that forms because of those early relationships. Now we're going to talk about this theory of object the relations that grew out of her work. And we'll talk now about Melanie Klein. And she was working with children evacuated during the Blitz. Another Dr. Fairburn was treating adults shaped by emotional deprivation. And Winnicott was a pediatrician who turned psychoanalyst, and he spent years watching mothers and infants under extreme societal strain. They worked around the same time, came to a very similar conclusion, was that it's not drives, as Freud would have said, that shapes personality, but it's the relationships, especially the ones we internalize before we can speak. And who we're having that relationship with is usually the caregiver. So the caregiver infant dyad was the focus of their research and the underpinning to their theories. Freud was very much, these are primitive drives making you do the things you were. It's a little determinist and fatalistic. So the question is, what did the child have to do internally to survive their earliest relational environment? That's the question you're supposed to be thinking about when you see somebody with manifestations of personality disorder. What did the child have to do internally to survive their earliest relational environment? Because the nervous system was immature. So the child absorbs not just what the caregiver does, but who the caregiver is. Are they stable or unstable? Are they attuned or dismissive? Are they warm or frightening? So object in this case is not a thing. Object is the internalized representation of a person, and that internal representation becomes the template for how we expect others to behave, how we interpret their motives, how we see ourselves in relation to them. So this might explain why two patients can walk into the same session with you and experience the same neutral silence and perceive it completely differently. So one feels safe and reflective. Another one might feel abandoned. Another one feels judged. They're not responding to the clinician, they're responding to those internal objects. Now, there's another concept to keep in mind here, and that is of object constancy. This is the ability to maintain an emotional connection with someone even when they're out of sight, unavailable, or even in conflict with you. This is a developmental milestone. People are not born with this. So when object constancy fails to develop, relationships then feel unstable and unsafe. So, for example, if you don't develop object constancy or it's impaired for some reason, a delayed text message feels like abandonment to you. A boundary feels like rejection. Someone disagrees and that feels like annihilation. The person cannot hold you are still there for me when you're not physically present. So that's the emotional core, by the way, of many of the cluster B personality disorders. Another thing that we need to pay attention to is this concept of splitting and integration. Splitting is one of the earliest psychological defenses. So the infant cannot hold complexity yet, right? Caregivers are either all good, soothing, perfect, safe, or all bad, frustrating, frightening, withholding, whatever. Integration then is the ability to hold mixed feelings about the same person. It's like a high level of developmental achievement. When a splitting persists into adulthood, you will see things like idealization and devaluation, love and hate. You're perfect, you're evil. Saint, Satan, right? That's kind of what that looks like in adulthood. So this is not manipulation, by the way. We see it as that, we perceive it as that. That's our own issues. The issue here is developmental arrest. So the patient is experiencing you with the emotional logic of a young child who cannot tolerate that someone they need might also disappoint them. So object relations teaches us that the personality disorders are less about the behavior and more about the internal world. A world that's built from fragments of early relationships. Sometimes they're cohesive, but sometimes they're tumultuous and split. Okay. Now, if you want to understand personality disorders, we need to have two lenses. How the child bonded and how the child internalized. And attachment theory explains the bonding. Object relations explains the internal world built from that bond. Let's see a question here. Okay. Do you think there should be a balance of both positive and negative relationships in order to allow the child to experience stress and build resilience? Meaning, if you always feel safe, you always feel coddled, the child will grow up unable to adapt to relationship stressors and would lead to personality issues. The problem with the question is you're not considering the developmental milestone. So let me go through this a little more and you'll see what I mean when I say that, because your intervention has to match the developmental milestone of the child. We certainly don't want to get in a situation where you are doing what we now call lawnmower parenting, right? where you pave the way for the child so that they never experience any distress in their life. Because essentially what you can do is derail that autonomy versus shame and doubt. If you do everything for this child and don't let them build the ability and learn to take initiative and develop autonomy, then you can cause harm. You can make them not have autonomy and initiative. So, object relations explains the internal world that is built from the bond that is described by attachment theory. Now, attachment theory is Bowlby and Ainsworth, and you'll get more into this when you get to the counseling class. But John Bowlby was a British psychiatrist working again after World War II, trying to understand the emotional fallout in children separated from parents. Ainsworth expanded on his work, and she created a research foundation for how early attachment patterns shape lifelong emotional functioning. Attachment is the child's first working theory about the world. So, what we're asking here, the child's asking, are people safe? Do they come when I need them? Am I worth coming for? Those are the early experiences that crystallize into the internal working models, the mental representations of self and others that guide how we interpret every relationship. So there are several kinds of attachment listed here. We have secure attachment, anxious, and avoidant. And so let me tell you about these. So secure attachment, this is the caregiver is reliable, attuned, and safe. The adult outcome is emotional flexibility, stable intimacy, and resilience. So that means that this was like the good caregiver, the one we need to have. Anxious attachment, this is more common. The caregiver is inconsistent, sometimes warm, sometimes unavailable. The adult comes out as hypervigilant to rejection, afraid of abandonment, and seeks reassurance. Now, you can see this in some relationships to varying degrees and intensity. They may have an anxious attachment. Avoidant attachment, this is where the caregiver was distant, dismissive, emotionally unavailable. What you have here is an adult that learns, I don't need anyone. They suppress vulnerability and closeness. This could be like you're hypermasculine, I can do everything on my own, I don't need anything from anyone. This could be the, it's just me and nobody else but me. Because I have been disappointed so much, so long, no one's ever been there for me. I've had to learn to do it all myself type of attachment. The disorganized attachment, this is a caregiver that was either frightening or frightened, right? A source of comfort and danger, very extremes. This creates the groundwork for chaotic affect regulation. This person may dissociate. This person is the one that may manifest a lot of cluster B patterns. Attachment theory answers the question, how did the child learn to expect relationships to feel? Object relations theory, this is what did the child do internally with their relationship experiences? So an internal object is the mental representation of the caregiver, not only how they acted, but how they felt to the child. Now, these internalized images become these templates for how do you read people? How do we regulate emotions? And what can we expect from intimacy? In infancy, the child cannot integrate this complexity. So people can be all good, all bad. And so when we bring this all together, attachment will tell you how the wound was formed, if they have a wound. Everyone's got some kind of wound. Object relations tells us how the wound was internalized and reenacted. So together, these are going to explain why personality disorders are not random behaviors. These are just old relational blueprints running on adult hardware. So if your question is like mine, so what? That was then, this is now, grow up. What's going on? Well, we talked about Mahler's attachment object relations. So the obvious question we'll never ask this cleanly, but you should, is the so what? Why do I act this way? Or why do they act this way? Where did this come from? Where did you learn to behave this way? It's the same question we ask. This used to be more common. You'd ask, who raised you? How did this happen to you? Same question. So we turn this theory into a question. So when someone comes in with a volatile relationship or chronic emptiness or rigid perfectionism, I want you to hear a developmental question hiding underneath the symptoms. What did I have to do as a child to stay connected and survive? That's the frame. Personality patterns are learned survival strategies that got overlearned and the software never got updated. So how you do this could be by exploring early memories of significant people. So in real life, what do? Well, you ask gentle, targeted questions about early relationships. This is your family history. Tell me, who raised you? What were they like on a good day? What were they like on a bad day? When you were upset as a kid, who noticed? And what happened? Who did you feel safest with? Who did you feel you had to perform for? What you're doing with these questions is you are mapping their internal working models and internal objects. Mother, father, siblings, nanny, au pair, 3 nannies and an au pair. Depends on the world you work in, without turning this session into a blame narrative. You don't want this to be, it was your horrible mother, okay? It's not that. Because the grace you give them is you say, maybe they did the best they could given what they had to do at the time. And it is possible that the best they did was still not good enough. So it's not malicious. The other thing you may want to look into is identifying any sorts of traumas that may have occurred at key stages. So keeping Erickson in mind with respect to having somewhere to anchor those key stages is helpful. So then you listen for these ruptures. So separations, losses, moves, hospitalizations, a chronic illness, violence, substance use, mental illness in the caregiver, divorce. At what age did the divorce happen is huge. Moments where the child had to grow up too fast or disappear to stay safe. So you're not just collecting trauma trivia here. What you're trying to do is connect the dots. Of course you fear abandonment. Your caregiver actually disappeared. Of course you overfunction. Love was contingent on performance. Of course you don't trust intimacy. Closeness was paired with danger. So you're not just managing symptoms, you're reading a life story written into someone's nervous system. When you ask, how did you learn to cope with this way, you're opening the door from shame to understanding, from fixed personality to the possibility of change. Now, this all sounds very Pollyanna and very sweet, like it's going to go just like that with the insight. It does not go just like that because they have to learn to trust you and actually do the things you prescribe. And that takes a long time. So Mahler and Erickson are describing the same developmental terrain just from 2 different attitudes. So Mahler is like zoomed in on the mother-infant dyad. Erickson is zoomed out on the psychological task of the period. So Mahler does differentiation from 6 to 10 months old. And she has this 0 to 2 months age group, which she calls the autism phase, the normal autism phase. Not autism in the way we say it today, but basically what this means is normal autism means that the newborn is basically inwardly focused. Okay, they're not reading the caregiver's emotional states. They're not regulating. They're just simply trying to survive. They're just focused on them. That's a normal, inwardly focused 0 to 2 month old normal autism. Okay. She then goes 2 to 6 months and calls this normal symbiosis. Now, here, the infant and caregiver feel like one emotional system. You can't tell where one ends and the other begins. The baby's sense of self is fused to the caregiver, and the caregiver's responsiveness begins the wiring that the infant's core sense of safety is going to need to form. Pay attention to that, 2 to 6 months of age. This is where co-regulation shapes the earliest emotional blueprint. This is really interesting because when you're trying to get an infant to sleep and they just won't relax, this is almost like poodles. They sense the stress and energy in the air. They can feel mom's anxiety and sleep deprivation and stress response, and they're picking it up and it's dysregulating their system. So you kind of need mom to calm down, and the kid's going to take their cue from mom. Differentiation 6 to 10 months. This is the moment the infant notices, wait, I'm me and you're you. So this is where you might see them start to glance back at the caregiver while they explore the floor, right? You will see stranger anxiety come out here. This is the dawning of separateness as a concept. So if the caregiver responds warmly and predictably, the child learns, I can explore and you'll still be there. And this becomes that scaffolding for later independence. Erickson, from birth to 18 months, calls this the trust versus mistrust. So Erickson translates the same developmental choreography into a psychological task. Can I trust the world? Can I rely on the people caring for me? So if the infant's needs are met predictably, the world becomes a safe base for them. And this is complementary to Mahler, who says the child is separating. Erickson will say the separation only works if trust has been established. So without trust, exploration becomes dangerous, not liberating. Without trust, autonomy becomes terrifying, not empowering. So when we connect these two models for personality together, you have Mahler's differentiation process is unstable, and Erickson says trust is not established. The child will grow into an adult who will struggle with abandonment fears, mistrust of intimacy, identity instability, panic where others pull away. So in other words, these seeds of many personality disorder presentations are planted right here before the child can even walk. Now, thank you for the comment about mother or dad, etc. You have to keep in mind the generational time period of when this was. You can extrapolate to dad, but the fact of the matter is the more common, the norm where the research was actually done was mother-child or caregiver-child, which was typically female-child. So I understand and I appreciate the modern sensibility, but what we ought to do is look at the more modern research and see what is actually the situation. We would more modern say, oh, everyone's interchangeable. That's not exactly the case. It's kind of hard to replicate breastfeeding. It's kind of hard to make the separateness happen when you're attached at the chest. So I appreciate the modern sensibility, but for the purposes of the timing of when these people worked, practiced, did their research, that's why I typically say mother, because that's what the research that they're doing is referring to. Okay, so here we are now at 10 to 18 months old, and this is the phase where the toddler becomes a tiny explorer with very fragile ego. So every step they take is shaping the personality that will follow them into adulthood. So Mahler describes this as the love affair with the world stage. So the child becomes mobile. They're crawling, they're standing, they're toddling. Their mobility is giving rise to this psychological independence. So you see them move away from the caregiver with a burst of confidence, and then they look back every few seconds to make sure that that caregiver is still there. So that's the back and forth dance that's critical, that needs to go on. The child is almost acting drunk with new power. They're opening drawers, they're grabbing objects, they're moving further away. They start to dart into traffic. They begin to feel, I can do it myself. That's the autonomy. This is the earliest flicker of agency. Boundary testing is popular here, so they touch what they shouldn't touch, climb where they should not climb. It's not defiance, and that's important for anticipatory guidance. They're not being defiant, they're being experimental, and that's a normal thing for that age and stage. They're very concerned about the safe base still, though. So every bold step presupposes one belief. Every time they take a step, they believe someone is watching out for me. And if the caregiver is steady and the child learns that independence is safe, and then it is. But if the caregiver is inconsistent or intrusive, then the child learns that independence is dangerous. And we don't want that. Erickson labels the stage of 18 months to 3 years as autonomy versus shame and doubt. And he zooms out. He's translating this developmental dance into a psychological conflict. Will the child experience autonomy, or will they learn shame and doubt? And this is where toddlers will try to assert themselves. No, mine, I do it. Right? That's not misbehavior. This is the identity formation. The healthy outcome would be confidence, when the exploration is encouraged, or this internal sense of capability. Pride is shown in mastery. The unhealthy outcome of this would be shame, when independence is punished or ridiculed, or doubt when the child's initiatives are over-controlled. Fear of failure when mistakes are met with criticism rather than guidance. So too much control breeds perfectionism, fear, dependence. But too little safety will breed things like impulsivity, chaos, and insecurity. So, we need it just right, not too much of any one or the other. So why this stage matters for personality disorders, how a toddler is responded to during this phase shapes their adult relationship with autonomy and boundaries and confidence. So if all things go well, this adult trusts their abilities, they can take risks, they can tolerate frustration, they don't collapse when they're corrected. If things go poorly, you get things like dependent personality tendencies, fear of making decisions, avoidant personality disorder tendencies, shame-based withdrawal, obsessive compulsive personality disorder. This is rigid perfectionism, but it's born from a fear of criticism. You may see borderline traits, which is unstable autonomy linked to inconsistent caregiving. This stage writes the script for how someone will handle independence, boundaries, mistakes for the rest of their life. Do I think moving a newborn into a separate room and using methods like cry it out potentially result in insecure attachment? That is one theory. That is one theory. I would say make it age and stage dependent. And I don't want to encourage co-sleeping just for the obvious risk of smothering. I'm not completely opposed to separate rooms, but I think that they need to be appropriately developed at the time. And you're really going to have to make up a lot of good parenting, if you will, when they're in your sight. Now, this emotional storm here happens at this reapproachment stage in Mahler's 15 to 24 months or initiative versus guilt in Erickson's 3 to 5 years. So, where the need for closeness and the drive for independence crash into each other is here. So, if you understand reapproachment, you understand half of borderline personality. So Mahler's reapproachment, the toddler is pulled in two directions at once. I want to do it myself, but don't go too far. I still need you, right? There was an off-Broadway play years ago called I Love You, You're Perfect, Now Change. Okay, so this goes on. And this oscillation is not misbehavior. This is the child's internal world stretching and tearing and reforming. Okay, they're developing, they're growing. There is no growth and development without pain, discomfort, suffering, and distress. You're not going to grow and develop. So that's a part of life. And part of good psychological health is developing the capacity for that. Because kids will learn very early on, life does not get easier. You're adults. Life has not gotten easier for you this year, has it? Now you're in graduate school and you still have to go to work and you're taking tests and you have families and taxes are due and you're renewing your malpractice and you have demands. Life does not get easier. The goal is you build capacity and you get better at doing harder things so that you're not thrown by a loop for all of these sorts of things. So this oscillation here, not misbehavior, the key features in this phase of development here is ambivalence. The child wants independence and proximity. Emotional turbulence is going to come out in the form of tantrums, clinging, protests, and sudden reversals. So think of your toddlers. And what they will do is constantly seek reassurance. So the toddler is constantly venturing out, and then panic rises, and then they return, right? That's the reapproaching. This need for attunement, they require a caregiver who stays steady through the push and pull, right? If the parents remain steady and keep their game face on and don't panic when the kid panics, the kid's going to know they're going to be okay. This is like when your toddler falls and skins their knee. The reaction of the parents will often determine the reaction of the kid, right? If mom goes, oh my God, and starts to bawl and cry, kid's going to panic and bawl and cry. When my son fell down at 3 weeks, 3 years old, he'd fall on the sidewalk. My wife would go, and then I would say, safe. So my reaction to safe, he thought he was going to be fine, got up and off he went. So that's kind of what they're doing. They're reading the room, they're mimicking. So this phase teaches the child that I can be separate without losing connection. Well, what happens when this reapproachment goes wrong? If the caregiver is inconsistent or punitive or overwhelmed or unavailable, the child learns a dangerous emotional lesson. And that is when I move away, you disappear. And that becomes the root of abandonment fears and frantic reassurance seeking and emotional layability and splitting. You're perfect, you're evil, I love you, you hate me, I hate you, I love you. Unstable independence, I want help, leave me alone. So when reapproachment disruption creates the template for these borderline attachment patterns. Erickson expands this into a developmental drama, so into broader psychological tasks. The questions he's asking are, can I take initiative without being shamed? Toddlers begin planning, imagining, they initiate play, they test limits, just like in reapproachment, but now with a little more sophistication because they're older. So the healthy outcome here would be confidence in one's ideas, joy in independence, a capacity to assert oneself. The unhealthy outcome would be guilt when initiative is punished, or hesitation when attempts at independence are met with criticism, or self-doubt when assertiveness is framed as bad or selfish or too much. Guilt becomes internalized as something is wrong with me for wanting, for trying, for asserting. So to tie these two guys together, reapproachment is this emotional dance. Initiative versus guilt is the psychological interpretation. So together, these things form a script for adult relational styles. So if things go well, the adult can assert needs without shame and can tolerate closeness without panic and can negotiate conflict without collapsing. But if they go poorly, we get borderline personality traits of fear and abandonment and emotional whiplash and clinging, then pushing away. We get avoidant personality disorder, things like shame about needs, fear of being too much. Dependent personality disorder traits could be things like excessive seeking of reassurance. Narcissistic traits may be things like brittle independence, masking abandonment terror. This is the stage where the core emotional dilemmas of personality disorders are born. I want connection, but I fear it. I want independence, but I don't feel safe with it. So, if reapproachment is the emotional storm, object constancy is the moment the clouds finally part, this is the stage here where the person grows up feeling emotionally anchored and relationally adrift. Well, or relationally adrift, I should say, and. Either you're emotionally anchored or relationally adrift, and it's a little fatalistic because we say for the rest of your life. Now, it may be there for the rest of your life to varying degrees of intensity, and you can learn coping skills that are effective as you're older and rehabituate them. So Mahler's object constancy here is one of the biggest developmental achievements of early childhood. This is the child learning emotionally, not intellectually. You still exist when I can't see you. And even more importantly, your love for me continues when you're not physically present when I'm frustrated with you. Now, this matters because the child will no longer panic when the caregiver steps out of the room. They tolerate brief separation, they explore with increasing confidence. Emotional regulation becomes possible because the caregiver is now stable, inner presence for them. Object constancy is the internalization of safety. And what happens when object constancy breaks down? The caregiver's inconsistent, frightening, emotionally absent. The child can't internalize a good, stable object. This leads to that fear of abandonment and emotional volatility and the clinginess. Does all that sound familiar? Same cluster B things we've been describing. Without object constancy, every conflict feels catastrophic, and every separation feels like abandonment, and every relationship is unstable. Erickson extends this 5 to 12 years old. So Erickson moves us ahead into middle childhood, the school years. And this is when the child's internal world is like robust enough to engage with the outside world. So the questions here that the kid is asking are, am I capable? Do I have something to offer? This is where children will develop stable sense of self-worth, confidence in their abilities, pleasure in mastery and competence, pride in contributing and achieving. And the healthy outcome here will be a strong work ethic, persistence, resilience in the face of challenges, willingness to try new tasks. And the unhealthy will be things like feelings of inferiority, avoidance due to fear of failure, dependence on external validation, shame when performance doesn't meet expectations. So if object constancy was not established earlier, then their industry becomes fragile. The child may achieve, but they can't feel secure about their achievement. Object constancy is building that emotional floor, and industry is building those psychological walls. And together, they're going to determine whether a person grows up feeling anchored and confident and capable or unstable and ashamed and relationally brittle. So the adult patterns, when these stages fail, borderline personality traits, rapid emotional shifts, intense fear and abandonment, narcissistic traits, compensatory grandiosity, masking that deep inferiority, avoidant personality, chronic self-doubt, fear of criticism, dependent personality, over-reliance on others for stability. A patient's adulthood is just often a reenactment of the developmental moment. Can I hold on to love when it's not in front of me? Can I hold on to worth when I'm not performing perfectly? So take a look at this scene here. This is a scene that's pretty accurate. This is Abilene gives the child a stable internal object, consistent presence, consistent affirmation, unconditional positive regard, and predictive emotional availability.
You are small. You is important. You is small. You is you is important.
So by the time the patient walks into your office with some entrenched maladaptive pattern, we're not looking at a single moment of bad behavior. We're looking at a lifetime of predisposing vulnerabilities colliding with precipitating stressors. So we're going to talk about the same formulation, 5 Ps we've talked about every week, but here we are. These predisposing factors could be things like genetics and brain structure, correlation, not causation. There's no single personality disorder gene, but we do consistently see heritable traits. So you can see traits inherited of impulsivity, emotional reactivity, aggression, harm avoidance, and these can cluster in families. And some MRI studies will show differences in like amygdala hyperactivity and prefrontal underregulation, impaired threat processing, and the like. These are not destiny, okay? But these will shape the temperament that a child brings into the world. Another predisposing factor to consider is trauma and neuroplasticity. So early trauma reorganizes the brain towards survival, not connection. So the child becomes wired for threat detection rather than emotional regulation. And neuroplasticity can work both ways. So maltreatment can strengthen a maladaptive circuit, but consistent caregiving can repair some of them. So trauma is not the cause of every personality disorder, but it is a common accelerator. Another thing to keep in mind is substance exposure. So prenatal or chronic household use, exposure whether in utero or through growing up in a substance-saturated environment. That disrupts emotional learning, attachment security, and impulse control. How? Well, I drink. I never got drunk and lashed out. Yeah, but the thing is, when you drink or use, you're not quite aware. You think you're acting normal, but what you're not seeing is the fact that your kid is picking up on your slower than normal response time, how you're more permissive or more rigid in the setting of the alcohol, which or the drugs or whatever, which is leading to that inconsistent parenting unit. The predisposing factors will explain to you a vulnerability, but they do not explain why symptoms are suddenly worse. Remember, we don't have emergencies. No one comes in because one time I did this one thing. There's typically a long pattern, and then there's a precipitant, a precipitating factor. That's the catalyst. That's the moment when the chronic vulnerability became acute dysfunction. So what are some things here? Public or relational attention to maladaptive behavior. So this is where personality disorder traits will flare up dramatically. When the individual feels, say, criticized, exposed, or evaluated, the primitive coping systems activate. So where might this be? How might you see it? Non-suicidal, self-injurious behavior, right? Often escalates when the internal distress meets the external scrutiny. or hoarding behavior, right? This could be triggered by loss, shame, or perceived judgment. Lack of self-care, often a passive communication of distress and or helplessness. You might see things like impulsive or reckless acts. These are acts done to regulate unbearable affect, not to break the rules. You may see violence and aggression, usually as a defensive posture rooted in some sort of threat sensitivity. You might see a corrective action plan to put in place. So, like they're at work and they've acted up, and now they're coming to see you because there's corrective action plan in place, and you're a part of that plan. Surprise. So, this is like a performance write up that can feel like annihilation to someone without object constancy. So, they respond with rage, denial, collapse, crisis. They may make suicidal threats, not to manipulate, but as a way of regulating. So when emotional pain exceeds the coping capacity, suicidality becomes a language. So precipitating factors don't create personality disorders, they just expose them. So as a clinician, you need to distinguish the vulnerability from the trigger. Predisposition, that's the soil. Precipitating stressors, that's the storm. Personality disorders grow where the two of those things intersect. Okay. So by the time this patient walks in, you're no longer looking at this one moment in time here, right? So what we have now are the protective factors that we need to talk about. So protective factors are reassuring to us because the patient comes in, ideally of their own volition, willing to seek help. And they may have things like a consistent interpersonal environment that stops the enabling. In other words, so for example, if the person is continually being bailed out, that becomes a perpetuating factor. But if you can block that, that can become protective because they can do something and expect a certain response rather than some days you give in and enable and other times you block. So then it's not perceived properly. Okay. Why don't we pause here for about 10 minutes before we get into cluster A, B, and C so that we don't overwhelm everybody. And then we'll come back in 12 minutes, or 10 minutes rather. All right, well, welcome back. So now we're going to talk about the three clusters in which the personality disorders fall into. So the first cluster we'll talk about is cluster A. And this is the world of the odd, the eccentric, the socially distant. These are the patients that are not dramatic, they're not emotional, they're not manipulative. They're just strange, uncomfortable, mistrustful, generally disconnected. So think of cluster A as the schizophrenia spectrum, but light. It's the same flavor, just not as intense. These are the disorders that share things like social detachment, cognitive or perceptual distortions, eccentric or unusual behaviors. These have difficulty forming close relationships. These are the patients that don't avoid relationships because they're afraid. They avoid them because they find them unnecessary, confusing, threatening. And that's a big distinction between cluster A and cluster C. So in cluster A, we have, first up, paranoid personality disorder. Now, the core theme in this disorder is distrust and suspicion. This is not the delusional level paranoia. This is just a style of interpreting the world. So they expect harm. They assume bad intent. These people read threats everywhere. And so the clinical sign that you will see is this persistent suspicion, misinterpreting benign acts as hostile. These people are very rigid, they're grudge holding, they're hypersensitive to criticism. Um, so here's how you can distinguish it, though. The distinguishing factor is these people can test reality, but barely. Their paranoia is plausible. It's not exaggerated. The next one is schizoid personality disorder. And the core theme here in schizoid is detachment and emotional coldness. These patients are not lonely, they're indifferent. And the key features here is they don't have a desire for close relationships. They have a limited range of emotional expression, and their preference is for solitary activities. They may come across as aloof or flat or disengaged. They're not anxious in social situations, they just simply don't care. So it's common to misdiagnose these people as depressed. Schizoid patients lack distress about their isolation. They're not bothered by it. And schizotypal personality disorder, the core theme here is eccentricity plus perceptual distortion. So this one is the bridge between personality pathology and a psychotic disorder. So they have odd beliefs or magical thinking. They may have unusual perceptual experiences. They may show an eccentric speech or behavior. They may have intense social anxiety and discomfort with close relationships. But the key here is schizotypal people are not delusional, but they are definitely a little off. You might call them oddly related. Their thinking is quirky, they can be tangential, they may speak with metaphor laden speech, they're difficult to follow. This is the cluster A disorder that is most genetically linked to schizophrenia. Cluster A patients rarely present asking for help with relationships or mood. These people present because someone else is uncomfortable, a coworker, a family member, law enforcement. Uh, so the goal here is to prioritize safety and function and not force emotional intimacy. You don't want to push insight here because they're going to interpret that as intrusion. So all you're looking to do here is stabilize the structure, create some predictability and some boundaries. So if cluster B says love me and cluster C says don't judge me, cluster A is saying leave me alone, I'm fine. Okay. So here, this formulation where we don't want to necessarily memorize the DSM criteria, but we want to understand the logic of the patient's behavior. So what made them vulnerable? What pushed them over the edge? Cluster A is not just random eccentricity. This is a patterned, predictable, and connected to some developmental stage. So family history of schizophrenia or psychosis could be a predisposing factor. Cluster A is genetically adjacent to schizophrenia, so you'll often see a first degree relative with psychosis or delusional disorder or schizotypal traits or chronic eccentricity. This doesn't mean that the patient is psychotic. It means they inherited a sensory processing and threat detection style that leans towards mistrust, odd beliefs, and perceptual sensitivity and social disconnection. Think of this like a neurobiological blueprint for suspiciousness. Other things that may have predisposed include things like childhood trauma, especially things like emotional neglect. Trauma for cluster A doesn't always look like abuse. Often it's absence. So emotional invisibility, lack of attunement, inconsistent caregiving. And it typically has happened at that developmental stage of trust versus mistrust. Something has disrupted that stage. And there's a persistent sense of threat without the emotional mirroring. And there's difficulty in reading relational cues. With neglect, they develop this inward retreat, this internal fantasy world. So these children learn early that people are unpredictable, people are unsafe. The world is best navigated from a distance. And this will give rise to the detached, eccentric, suspicious, interpersonal style that you see in adulthood. So, what might be a precipitant that brings them to care? Well, it's the long-term vulnerability, and now what activates that symptom? So it could be any sort of acute stressor like a loss of job, partner, housing, stability. These stressors will heighten the hypervigilance and decrease that cognitive flexibility. So under stress, the whole world becomes sharper and louder and more threatening. Another one is social rejection or isolation. So that's the irony of cluster A, is that the very traits that cause the relational discomfort happen to create the conditions for further isolation. And then isolation fuels that symptom escalation. So the pattern you'll see is this misinterpretation of neutral interactions, withdrawal, loneliness, heightened suspicion, increased reliance on this internal fantasy or odd belief. And then they also may have things like a paranoid misinterpretation. That's like the final spark. Paranoid misinterpretation is not a delusion. It's just a distorted lens that overlays every interaction. So, for example, a common trigger may be they overheard a conversation, or they misread an ambiguous facial expression, or they have bad workplace feedback, or they complain about neighbors' behavior, or they overinterpret a social media post. And then what happens is that distortion that they have will lead to things like withdrawal, hostility, avoidance, preemptive defensiveness, misreading motives. So the patient sees danger where there's ambiguity. And then they retreat, not because they're psychotic, but because their perception system is calibrated only for threat or primarily for threat. So the question here is why? Why does the patient behave this way and why now? Why are these particular triggers? This will help you in understanding, and this will prepare you to anticipate worsening of symptoms, and you want to help you avoid a misdiagnosis of psychosis, and you want to intervene early when you see warning signs. This formulation of why and why does the patient behave this way helps you build a treatment plan that's rooted in their psychology. So you might say, so the holidays are coming up. What's going on there? Or so you season of change, or you mentioned you have a job thing coming up. So what you're trying to do is cast a future-oriented net to figure out where those vulnerabilities are, and maybe you can do some anticipatory guidance that's psychologically congruent. So once the symptoms appear, the question shifts to, well, what perpetuates this? What keeps it going? And what stabilizes the pattern? And where, if anywhere, are the leverage points for change? So what you want to see here is basically the self-reinforcing factors that are not random. So for example, avoidance is both the symptom and the fuel. And the less they interact with others, the less corrective feedback they receive, and the more entrenched their paranoid eccentric interpretations become. So you'll see like patterns of avoidance, which reduces opportunities to test reality. Isolation increases misinterpretation. Social withdrawal becomes a comfort zone. Avoidance becomes a primary coping strategy, because the avoidance is protecting them emotionally, but it's starving them socially and cognitively. So you can see how this perpetuates the symptomatology. The cognitive distortions, this is the engine of cluster A. So distorted explanations for ambiguous events, like, for example, they said, people are watching me. They said that because they don't like me. I know what they really meant. I can't trust them. They'll betray me. And so you'll see things like features of misinterpretation of neutral clues, or magical thinking, which is very schizotypal, or some very rigid, suspicious interpretations because they're avoiding relationships. And these beliefs never get challenged, right? This is what we call the quintessential echo chamber. And then they grow stronger. Right. And you can see this on the political spectrum as well on both sides. People get isolated, put themselves in an echo chamber, keep reinforcing their own cognitive distortions, are convinced they know everything about the world. It's egocentric for them. And so the other thing that perpetuates this is this limited poor insight. So cluster A is egocentric. The patient believes that their worldview makes sense. They don't see their thinking as distorted. They see the world as dangerous. And so this poor insight leads to a refusal of help, resistance to feedback, difficulty in engaging in therapy, lack of motivation to change. So without insight, there's no internal pressure to modify the behavior that's causing the problems. That's why we want them to have insight. Now, there are some protective factors, things that actually help, not what we wish would help, but what has real world clinical utility for these people. So, therapeutic support therapy is difficult but not impossible for this group. The goal is not emotional intimacy. The goal of the therapy is skill building and challenging distortion. So CBT for cognitive restructuring, reality testing practice, social skills training, very gradual exposure to relational experiences. You need to be predictable with these patients. Inconsistency will breed mistrust. I'll tell you an example. So normally I wear a bow tie ever since I've seen every single patient. One time I walked into this one person's home with no bow tie, and suddenly I've been seeing them for years. You're not my doctor. I don't know you. My doctor always wears a bow tie. So I broke the consistency. And so that took a lot of effort to repair. So note to self, always wear a bow tie when you're going to see these people because they have developed a picture of stability by looking at that. Something that I didn't expect. So these patients do better when the world is orderly, stable, rule-based. Good things for them, or programs that are useful, will be things like vocational programs with clear expectations, day treatment programs, supportive employment, consistent routines. The goal of all this is to reduce their stress and decrease their paranoid thinking and minimize the ambiguous interactions. Basically, you're hoping to create a safer world for them. And that's kind of the best you can hope for, because in reality, it's not very realistic to create a very safe, routine, and expectant world. Ideally, you want to help these people build capacity. But in the short term, breaking the pattern of isolation is going to be most useful. So another thing about community support, programs focused on low pressure social contact, like psychosocial clubhouses. In New York City, we have, what's it called? Fountain House. It's a drop-in psychosocial clubhouse. Structured recreational groups, activity-based programs, things that allow for gradual re-engagement. And the goal is to build tolerance for interaction. You want to reduce their loneliness, provide some corrective social experiences, and ideally increase their functioning in some real-world settings. Low stakes socialization will give them the practice they need without a threat. Cluster A, this is not a disorder of emotion. This is a disorder of interpretation. The perpetuating factors strengthen the distorted lens. Protective factors help clean it slowly, cautiously, meaningfully. So here's a grid for you to compare them all side by side. And you can use this slide as an anchor. When patients present with odd behavior, paranoia, social withdrawal, the question is always the same. Is this a personality disorder or the schizophrenia spectrum? And the differences are subtle, but they're critical because officially there's no medication for the personality disorders. So, schizoid personality disorder, they are socially indifferent, emotionally flat, cognitively intact. There's no desire for closeness. There's a restricted affect. There's no significant cognitive distortions. There's no perceptual disturbance. They may withdraw under stress, but they don't break reality. The insight they have is, I'm fine, leave me alone. The differentiator here is they are not psychotic and they are not paranoid. Their world is internal, quiet, and detached. Compare that with the schizotypal personality, who's eccentric with perceptual oddities, but not frankly psychotic. So they have odd beliefs and magical thinking, maybe some unusual perceptions like illusions, not hallucinations. Illusions means they are just misreading something that's really there. A mirage is an illusion, right? Hallucination is they are seeing or hearing something that's not really there. That's the difference. So you should know the difference between an illusion and a hallucination. Now, they may have a constricted and awkward affect. They may have a strange speech pattern. They may be vague and heavy into the metaphors. They may be tangential. You should know the difference between circumstantial and tangential. You might see that on a test somewhere with respect to the mental status exam. And then under strong social anxiety and under stress, you're going to find some transient, non-sustained psychotic-like episodes. The insight is limited but not absent. Schizotypal lives on the soft edge of psychosis but maintains reality testing most of the time. Paranoid personality disorder, on the other hand, this is a chronic mistrust, but no delusional system. And their clinical profile is one of a suspicious, hypervigilant, one who misreads intentions as hostile, cognition's intact, suspicion is plausible but exaggerated. There's some social detachment because intimacy equals threat to them. High stress leads to more mistrust, not hallucinations. The insight here is, I'm not the problem, other people are, which is common with most personality disorders. Paranoid personality misinterprets reality but doesn't lose it. Now, compare that with schizophrenia. This is a loss of reality, deterioration, and functional decline. They will have hallucinations, be they auditory or visual. They may have delusions, which are fixed, bizarre, or elaborate. Look up the difference between fixed, bizarre, and elaborate delusions. They may have disorganized speech, negative symptoms like flat affect, alogia, avolition. They may have impaired functioning, poor insight into illness. The psychosis worsens under stress and persists. And the key differentiator here is schizophrenia involves the rupture with reality. Personality disorders do not. So there are some cross features that help clarify the diagnosis. So cognitive distortions versus delusions. Schizotypal, they have odd beliefs and magical thinking. Paranoid personality, they have suspicious interpretations. Schizophrenia, fixed, unshakable delusion. Uh, um, Paranoid disorder distorts reality, but schizophrenia replaces it. And they may have some perceptual changes as well. So schizotypal, they'll have illusions. I felt someone behind me, they might say. Schizophrenia hallucinations will be like, a voice told me this. Okay. The speech pattern's a little different. So in schizoid, you'll have minimal but coherent speech. In the paranoid, you'll have detailed, guarded speech. In the schizotypal, you're going to have metaphorical, odd, tangential. And in the schizophrenic, you're going to have disorganized, incoherent with derailment. So you should, if you're not familiar with those terms, you can look up those speech-defining terms of disorganized, derailment, circumstantial, tangential, etc. And then finally, the response to, well, not finally, but two more, the response to stress. There's schizoid. When the stress happens, they hide. Paranoid, they escalate the mistrust. Schizotypal, they may become briefly psychotic, briefly. Um, and then schizophrenia, the psychotic symptoms will intensify. With respect to insight, the schizoid will say, this is who I am. With respect to paranoid, they're going to say things like, you're the problem. Rather, in schizotypal, you'll have things like, I know I'm weird, but it's just how the world works. Schizophrenia, profound lack of insight, especially in the acute phase. They're just not even giving you anything here. And so if the patient is odd, eccentric, or suspicious, but reality remains intact, think cluster A. And you can spend time in subsequent sessions trying to figure out which one in the cluster A. But if the reality is fractured and they have delusions, hallucinations, disorganized thought, think schizophrenia. For your test, I will ask you to distinguish between these personality disorders by giving you signs and symptoms of each one, and then you will be able to pick whichever right one happens to be in front of you on the page. Okay, let's talk about cluster B now. So cluster B, patients live in intensity and intense emotions, intense relationships, intense reactions. Think the TV show, The Housewives of whatever city you happen to be watching, Beverly Hills, Utah, Georgia, New York, whatever Housewives show you're watching, you will see a lot of cluster B examples. I'm not saying they have cluster B, but they have a lot of examples that might fit this given the right circumstance. And the core problem area for this cluster B is the intense emotional expression, the impulsivity, the unpredictable behavior, the difficulty maintaining stable relationships, manipulative behaviors, though I prefer relational strategies that feel manipulative to others. So we're not supposed to call them manipulative. Remember, they're trying to survive. But when the countertransference is at an all-time high, we call them manipulative. And that's why we have to be in tune to the countertransference. So cluster B, believe it or not, is not drama for drama's sake. This is about a primitive coping system that is activated under stress. One of these, antisocial personality disorder, the core theme here is this exploitation without remorse. This is the disorder of rule breaking and deceit and a lack of empathy. The clinical hallmark of this is that general disregard for others' rights, lying, conning, manipulation, impulsivity, aggression, no guilt, no accountability. It's often comorbid with substance use disorder. Antisocial personality disorder is behavior plus attitude plus lack of remorse, not just criminality. Whereas borderline personality disorder, the core theme here is emotional instability plus abandonment fear. The borderline equals that affective chaos that you see. So the emotional thermostat here is broken. Every relationship becomes life or death. For the borderline, unstable relationships and a frantic fear of abandonment, impulsive self-harm, intensity and mood swings, identity disturbance, and chronic emptiness, these are very key features that manifest. Borderline, don't think of them as manipulative, think of them as desperate for coping. Histrionic personality disorder, their core theme is emotional excess and attention seeking. This is very costumed looking. Think of histrionic personality as emotional overdrive. They get connection through performance. Think of someone like, if you were to think of a character, think of Miss Piggy from the Muppets. Hi, I'm here. Mwah! And it's very big and grandiose. They're shallow, they're rapidly shifting in emotions, they come with a dramatic flair, they seek to be the center of attention, they may be seductive or provocative. Think I'm going to date myself here, but if you ever saw the TV show Roger Rabbit, the movie many, many, many years ago, Jessica Rabbit would have been this seductive, histrionic, pouty, basically manipulative through emotional demonstration. They're impressionistic in their speech sometimes. That's why when we talk about speech pattern, you may describe it as impressioned in some way. Histrionic patients will regulate emotions by amplifying them, their own emotions. And finally, narcissistic personality. This is like the du jour disorder of the day. Every social media has this on. So the core theme here is fragile self-esteem and defensive grandiosity. Okay, so narcissism is not confidence, it's armor. So features include things like grandiosity, entitlement, this need for admiration and supply, a lack of empathy, and rage when criticized, and we call that the narcissistic injury. The important nuance here is underneath the arrogance is this profound shame and vulnerability. And so these disorders, the emotional instability versus emotional strategy, in borderline personality, they have dysregulation. In histrionic, they have dramatization. In narcissistic personality, they have like this defensive superiority. And then in antisocial personality, it's like an emotional detachment. Their relationship pattern for borderline is this clingy and then pushing away. For histrionic personality disorder, it's attention and attachment. For the narcissistic personality, it's about domination and control, whereas antisocial, it's merely about exploitation as a game. They could care less to control. Impulsivity in borderline, it's self-harm and reckless acts. In antisocial personality, it's aggression and rule breaking because it's fun. And then histrionic personality disorder, you'll see rapid shifting and a lot of attention driven decisions. But narcissistic, you'll get impulsivity when the ego is threatened. Now, the manipulation is not malicious in most of cluster B presentations. It's simply a survival strategy that temporarily is regulating the emotions that they're finding unbearable. So cluster B is the cluster of raw feelings and primitive defenses and unstable attachments. So if cluster A fears people, cluster B feels people too much, too intensely, too fast. All right, so how might this come together? Well, cluster B, everything begins early. Okay, genetics, temperament, the emotional climate of the home. These are not random behaviors. They're just patterned responses shaped by some biology and the environment and whatever developmental injury may have occurred. So some predisposing factors can be things like a strong heritability with impulsivity or affective instability and aggression, especially when we're talking about antisocial personality disorder. But remember, genes load the gun. The environment pulls the trigger. So mood disorders in a family can lead to the affective instability. The impulsivity can lead to that chronic behavioral discontrol. In this antisocial personality disorder, this has the strongest genetic signal. And people with borderline, there is measurable heritability in traits. Now, with respect to childhood and environment, this is the big one. Trauma, neglect, inconsistency, and chaos are common in cluster B. So inconsistent caregiving, that is, a caregiver is present one moment and then unavailable the next, or emotional neglect. Child's emotions are ignored or punished. Abuse or high conflict households can set the stage for this. Unpredictable discipline. Sometimes you get away with everything, and other times it's like, severe punishment. So, according to Mahler, if early attachment is inconsistent, then children grow into adults who expect instability and abandonment. Now, there are some temperamental factors. So some kids come into the world with the volume dial already turned way up. They may have high emotional reactivity and difficulty self-soothing. They may have impulsivity and they may be very sensitive to rejection from the beginning. So temperament is creating this vulnerability, but the environment determines whether that vulnerability is going to actually be a disorder. Now, the precipitating factors could be the things like the stressful life events, the breakups, the rejection, the job loss, the being dropped off at daycare, however it's perceived, interpersonal loss, trigger symptoms, etc. Cluster B is self-worth. Self-worth is relational to them. So if the relationship wobbles, then the self-worth wobbles. It explains why you see things like emotional outbursts and impulsive decisions and self-harm and rage in the narcissist or acting out in the antisocial. And the other thing is interpersonal conflicts. This isn't just stressful, it's very threatening to their identity. So the big one with borderline is the abandonment fear. With narcissism, it's that fear of humiliation sensitivity. With histrionic, it's that fear of attention desperation. Um, with antisocial, you may see retaliation patterns. No one's going to get me. I'll get you back twice as hard, right? Um, it's not if you go high, we go low. It's if you go low, I'll go lower. That's antisocial personality disorder. Situational changes can also be a precipitant. So transitions that destabilize patients who are already struggling with emotional regulation, any major loss, job, person, moving, relationship ending, new responsibilities, etc. All of that can be triggering. Other things, especially in the narcissist, could be things like sudden shame or a fear of being replaced or a fear of failing, impulsive or chaotic responses. Cluster B symptoms don't come out of nowhere. What happens is they emerge at the intersection of their biology, their temperament, and whatever relational injury. And then they flare up when the patient feels unsafe, unseen, or unimportant. Now, perpetuating factors, that is to say, what keeps this thing going, it's the dysfunctional coping mechanisms, of course. And these patients aren't trying to be manipulative, except for the antisocial ones. They're trying to survive emotions that feel unimaginable. So attention seeking equals attachment seeking. I just want to feel close to you. Manipulative behaviors equals this primitive attempt to reduce anxiety. Reactions often reflect the fear of abandonment or rejection, not malice. So the behavior that makes sense once you understand that underlying fear. Now, another thing to keep in mind is this self-image instability, especially in the borderline personality. Identity is built on emotional weather. not on stable internal markers. Their internal validation system is malfunctioning. That dashboard light is on. So they'll have rapidly shifting sense of self. They'll have impulsivity, which is often tied to an unstable self-image. Relationships destabilize the self and vice versa. So if I don't know who I am, I don't know what I'm worth. Another factor to consider here is the limited insight. The insight isn't absent, it's just inconsistent. So this leads to repeated interpersonal failures, defensiveness, or externalizing blame, difficulty connecting actions to consequences, emotional spirals after a relationship that ruptures. So when insight flickers on and off, so does that accountability. But there are protective factors, and the protective factor is this willingness and structure. So change requires two ingredients. It requires willingness and a predictable container in which to practice. We call that the therapeutic frame. Structured routines reduce the chaos and help with the emotional regulation. Psychotherapy is most effective. This is where things like DBT and CBT really shine. DBT is good for emotional regulation, distress tolerance, and interpersonal effectiveness, whereas CBT is good for restructuring the entitlement and grandiosity and rigid beliefs. Theoretically, with narcissistic and antisocial personality, but I'll tell you the research is not promising, but it's kind of all we got. These two personality types are not going to be coming to therapy unless someone is forcing it. And I don't know what kind of buy-in we're getting unless there's an external reward for them. But suffice it to say, we need in this group, we're looking at skills before insight. And insight hopefully comes later. And if it never comes, that's fine. But suffice it to say, I need skills and good judgment. I don't, on some level, I've told you this before. If I have to choose between insight and judgment, I need good judgment because I don't care why you do the right thing. I just need you to do the right thing. Um, Now, let's talk about social support. So, stable relationships are corrective emotional experiences, but I will tell you, those social people are going to get some scars. And so, I'm not saying they should subject themselves to abuse as a live in therapist. Suffice it to say, socialization is good because it can help reduce reactivity eventually. And the goal is that it models these healthy boundaries and reinforces emotional stability and hopefully will protect against impulsive decisions and build some connection. Self reflection depends on who they are and how deep this runs. But when patients begin to take ownership of their behavior, then everything shifts. So, small gains could be things like self observation, recognizing patterns, taking some responsibility. These can dramatically reduce relationship ruptures, impulsive behaviors, and emotional chaos. Accountability in this case is not punishment, it's liberation from the old script. It's finally consistently holding them accountable. Now, antisocial personality disorder, the core issue here is a fundamental disregard for the rights and boundaries of others. So the key point for you to know is that they have a pattern of violating rules, norms, and laws. And manipulation tends to be a calculated, goal-directed emotional experience, is often shallow. Remorse is minimal or rationalized. So in this group, you need to think behavior first, emotion second. Antisocial personality disorder presents with actions that consistently disregard consequences. Borderline personality disorder. This is fundamentally a disorder of emotional intensity and relational instability. So the big thing to note here and pay attention to is the hypervigilance to abandonment cues. So you may find that this patient will decompensate when they get ready for discharge or when you tell them you're going on vacation. They may perceive that as abandonment, and then they may deteriorate. They may have rapid mood shifts driven by interpersonal events, impulsivity as an attempt to regulate distress. Self-harm or substances often function as an emotional escape valve for them. I just felt so bad I had to cut. It's not an uncommon thing to hear. The behavior makes sense in context because everything is about preserving connection and avoiding unbearable emotional pain. With histrionic personality disorder, this centers on the need to be seen, valued, and validated. So the key feature here is excessive emotional expression that can feel performative. Relationships can feel shallow because they're based on approval, not intimacy. You may have over flirtation or seduction or some sort of dramatic behavior, and that's used to maintain the attention. So the function here is connection, but the method is done with amplification. Narcissistic personality disorder is not confidence. This is a defensive shell built around a fragile esteem. Core symptoms of this include things like an inflated sense of importance, impaired with entitlement. There's intense need for admiration. Empathy is limited, often due to self-protective hyper-focus on self-worth. They'll demonstrate exploitive behaviors that arise as strategies to maintain some self-cohesion. Grandiosity protects the self from the intolerable feeling of inadequacy. So let me put this up here. Give me a thumbs up if you were able to hear the last video. Good. Yes, good. All right. Take a look here at the narcissist prayer. So, narcissistic personality disorder is a clinical diagnosis, not an insult. Now, popular media has absorbed the word narcissist as shorthand for anyone who's selfish, rude, unpleasant, but that's not what we're talking about here. So, as clinicians, our job is to diagnose patterns, not villains. So, I want to introduce you to Dr. Ramani Druvasala. This is one of the most visible public educators on narcissistic behavior. She's not teaching DSM-5 narcissistic personality disorder. She's describing relational patterns in narcissistic abuse. So this clip is helpful not because it diagnoses narcissistic personality, but because it illustrates how people experience narcissistic traits, the gaslighting, the minimization, the blame shifting, the emotional invalidation that can happen. So use this as an empathic window into what your patients may be describing, not as a tool for diagnosing someone in their life. And before I play this video, let us pray. This is the narcissistic prayer. This is a poem, not a diagnostic tool. It's an experiential tool. So that didn't happen. Gaslighting and denial. And if it did, it wasn't that bad. Minimization. And if it was, that's not a big deal. Invalidation. And if it is, that's not my fault. Externalization. And if it was, I didn't mean it. Lack of responsibility. And if I did, you deserved it. Entitlement and manipulation. So these patterns map onto that central defense mechanism of narcissistic personality disorder of denial, projection, rationalization, externalization, empathy deficits, fragile underlying self-esteem. So these examples help us understand the impact of narcissistic traits on others But remember that narcissistic personality disorder fundamentally is a disorder of self-regulation and fragile identity, not intentional cruelty, regardless of how it may seem. So the goal here is not to demonize, but to understand so you can treat the person sitting in front of you and protect the people affected by the behavior.
There are these archetypes and types of narcissism. And I think it's worthwhile to go through some of them. And you've outlined them in your book and written about it previously. Can you walk us through those?
Yeah, so the most classical form of narcissism that we most often think about is grandiose narcissism. And the grandiose narcissistic person is almost like our armchair textbook definition. Arrogant, pretentious, preening, look at me, status oriented, really cares about appearances. Interestingly, of all the types of narcissism, grandiose narcissistic folks kind of have the best outcomes, believe it or not, because they're not as victimized. Like, as long as things are going generally the way the grandiose narcissist wants. I'm not saying it's a healthy relationship. I mean, we're talking about really like matters of like, what's the best worst disease to get kind of thing here, right? So it's really a matter of, though, the grandiose narcissistic person really cares about appearances. They're very, very forward facing, right? So that's the grandiose narcissist. And that typically, even in the DSM and other diagnostic spaces, that formulation of narcissism is what we've classically focused on. However, especially in the last 10 years, there's been more focus on what's called vulnerable narcissism, which to me is probably the most important evolution in this conversation. And the vulnerable narcissistic person is the one we often miss because they're not quite as charming, charismatic, shiny, compelling. These are folks who are sullen, petulant, resentful, victimized, passive aggressive. They are angry at everyone in the world. They feel like everyone has gotten more than them. Why me? Woe is me? Witch hunt? Everyone's out to get me. And so, and also vulnerable narcissistic people may be more sad. They may be very socially anxious. So to somebody looking from the outside in, they'll actually say, this person's not narcissistic. They're kind of not well put together, actually. And they often sort of pull for being rescued, right? So a lot of people will get caught up in trying to help them. Let me give them an opportunity. Let me give them a couch to sleep on. Let me borrow them. Let me loan them some money. Let me help them. And then it becomes like this, literally a vortex, a black hole to which you could just keep putting more and more, and it's never enough. And they sort of remain frozen in time and space, no matter how much resource, time, support, encouragement you give them. That's the vulnerable narcissist. Now, grandiose and vulnerable narcissism are sort of like these kind of these complementary structures. If things start going wrong and wrong and wrong and wrong and wrong for the grandiose narcissist, they start looking like a vulnerable narcissist, sullen, petulant, aggrieved, everyone's out to get me. If things start going really right for the vulnerable narcissist, their grandiosity will pop out. So people are either more primarily grandiose or more vulnerable, but circumstances can kind of flip it and sort of make that other form of narcissism show up. The next form of narcissism.
Can I insert one thing please, just to clarify? One of the things that I heard you share previously is that vulnerable narcissist, even though we talked about women being the brunt of most of the narcissistic behavior, the receiving end of it, you typically would find when you do find a woman who's a narcissist, it's often more likely to be a vulnerable narcissist.
Right. Yeah, absolutely. So vulnerable narcissism is pretty much equally distributed between genders. Grandiose narcissism is much more prevalent in men. Malignant narcissism is where we're talking about that more severe narcissism. We may still see some of the charm and the charisma, but we can also see a callousness at this point, right? There is a lot of vindictiveness in the malignant narcissist. There is the willingness to take advantage of people's vulnerabilities, isolate another person. So the charm is really kind of short-lived and not nearly as shiny as it is with the grandiose narcissistic person. Malignant narcissistic people will be very controlling. And the way that might even show up in an intimate relationship is they may be intently focused on someone else. Like, I want to spend all my time with you. Why do you want to spend time with your friends? Aren't you into me? They might do things like buy them a phone as a gift, which is a way they can track them. I always tell young people, don't ever accept a device or a phone as a gift from someone you're in an intimate relationship with. It's very dangerous. You maintain your own phone accounts and your own devices always until you are so certain that this is a safe relationship. But that seems like a generous gift you could get from someone, right? So it's those kinds of things that a malignant narcissistic person would do. Those relationships can get dangerous, and of all the forms of narcissistic relationships, physical violence and aggression is going to be most likely to show up in a malignant narcissistic relationship, and then secondarily in a vulnerable narcissistic relationship. Then we get to some interesting forms of narcissism, most pointedly the communal narcissist. The communal narcissistic person is I call them sort of the shirt off your back narcissist. These are the people who seem generous. They seem like they're humanitarian. They seem like they're trying to save the world. They're out there putting out their message, and that's how they get their validation. So one will say, well, there's probably no such thing as human altruism. Is it anyone trying to do good in the world, trying to do it for some validation? That's usually not the primary motivation. And the reason we know this is if a communal narcissist isn't getting lots of cheers and congratulations and you're so great and you're the best, they will get quite angry. And they will usually take that anger out at family members, again, those people in their inner circle. So lots of people will look at us, even a celebrity seeming like, humanitarian, and then someday we'll see the leaks of people saying, oh my gosh, this was the most nightmarish thing I've ever worked on. Or their families will say, it was so hard because we couldn't even get support. Everyone said, our dad was the hometown hero and built a little league field, and yet we were all suffering with this really cruel person at home. That's the communal narcissist. At the highest, most severe end of a communal narcissist, we're seeing someone who looks more like a cult leader. At the more mild end of the communal narcissist, we're looking at that kind of really cruel PTA mom who's going to run everyone into the ground doing that, right? Then we have the self-right.
Because in their eyes, the ends justify the means?
But no, because in their eyes, they need to be validated.
Okay,
and this is a great way. This is a really great way to get validated. And so like social media really blew the communal narcissist kind of up, because I'm rescuing the animals on the beach. Tuesday is elephant rescue day. And it's like everything is something with them. And like, look at me, I'm so great, I'm rescuing the world. And they'll often get to be quite judgmental of others, like, well, have you done your volunteering this week? And you're thinking, lady, I'm not even able to get into bed before 10 o'clock. And I make time for other people. So it's all about them being validated and yet having run into some of those PTA mothers, very controlling, very invalidating, almost very cruel. And yet everything's like, I'm doing it for the kids. I'm like, doing what for the kids? Invalidating and destroying the souls of the other mothers? Seems like not a great way to do it. Then we have the self-righteous narcissist. The self-righteous narcissist, actually back in the day, that was a personality style called the anancastic style. It's like an obsessive compulsive style, not like OCD obsessive compulsive, but like obsessive in terms of obsessive with regard to detail, morality. These are often people who are very workaholic. They are judgmental. They are very, very stingy with money. They're punitive. They're cold. They often live very, very, very rigidly, obsessively ordered lives, like everything just so. And if anyone messes with their schedule, listen, if somebody wants to get up in the 4 a.m. and drink goat milk with kale, you do you. You let me keep sleeping, and don't judge me for not. But these are the folks who will shame other people. Well, I live better than you. I am better than you. And they're the folks who will say, if dinner's at 6 and someone has got sick kids and is quickly trying to gets there at 6:15, they'll say, well, dinner's at 6 and we have eaten. And so it comes off as very moralistic and cold. And if you grew up with a self-righteous, narcissistic parent, it is a horribly cold, cruel, invalidating experience, because a child feels like they're constantly being judged. These are kids who will say, we were very anxious as kids because we had to do everything they said. The rooms, there's like military, bedrooms, and the schedules were like that. And the the dinner table was such a fraught space. So it's a very, very cold, invalidating, like I said, moralistic, judgmental, work above all, shaming anyone who's had bad luck. The kind of thing like, well, if you'd saved your pennies, you wouldn't be in the situation. Not accounting for they'd lost their job and then they got very ill. There's none of that. Like, if you'd lived your life like me, everything would be fine. So there's a real lack of empathy and an entitlement in that style that comes out in a really self-righteous way.
It's so helpful to hear you break them down, because I can imagine that everybody listening is going to be thinking that there's probably at least one person that they know, and could even be somebody who raised them.
Correct.
That
Very
was
commonly.
Very commonly.
Yeah.
And with all of these across the board, I think the thing that is important to remind people is that often, because it takes many years, in the case of children, you don't know that your parent is narcissistic when you're younger, if you were unfortunately raised by something like that. So many people who are listening today who are saying, okay, yeah, this feels like somebody that's in my life, they also, regardless of what type it is, they have felt at some point in time that they were the cause or they were to blame. Where does that come from?
Right. So we as human beings are oriented towards attachment and connections. We need human relationships. Now, obviously, that's most pointed when we're children. To survive, we need attachment. There's no plan B. There's no other parents we can find. So we got to make the people we've got in front of me. That's why children can endure horrific abuse and still try to remain connected to a parent, because that's all we've got. But as adults, that doesn't go away. Our need for attachment persists. It's a very central core part of being a healthy human being. That means that when we're in a close relationship and these kinds of invalidating, negating, manipulative patterns show up, our first go-to isn't, I'm out of here. For many people, it's, how can I make this work? How am I contributing to this? And the more we can internalize it within ourselves, internalize the blame in ourselves, the more we can do something about it. So the child not only is told by the narcissistic parent that their needs are shamed, their emotions are shamed, their wants are shamed. The child is basically put in a position where they exist to serve the parent rather than the parent protecting them. There's no psychological safety in these spaces. So the child has to become smaller and smaller and smaller, and exactly what the parent wants them to be able to survive in those systems. When that child goes into adulthood, guess what they're going to keep doing in relationships? Be small and not show up in their whole self, because they're convinced if I do that, I'm not going to be able to be close to someone, right? And that's a very felt sort of an experience. So the child blames themselves. I'm a bad kid. I'm not enough. I'm not smart enough. I'm not good. I'm not a good kid. Basically, they internalize that. That becomes their identity, the identity of damage, the identity of shame, the identity of not being good enough, because that's in essence what the parent is implicitly communicating. That again dogs a person into adulthood. But if we can take this on ourselves, we can remain attached. Right. But if we see it in the other person, well, then that's a call to action saying, this isn't good for me. And then what? Then sort of the axiomatically, it means we got to go. And so anything to take away the we got to go. So we hold on to things like hope, or what can I do? Or how can I fix this? Or almost not seeing it. Like there's a dissociative quality when we're in these relationships. There's a phenomenon that Dr. Jennifer Frye calls betrayal blindness. We conveniently kind of don't see these things that will get in the way of us maintaining an attachment. Cognitive dissonance. We don't like it when the pieces don't fit. This is my spouse. They're really mean to me. How do I make the pieces fit? Maybe they just had a bad day. Maybe I'm not keeping the house clean enough. Those things are all put together. By the time it's done, a person truly believes they're the bad one. And then you throw some gaslighting on top of that. And the gaslighting where the narcissistic person is literally telling you not only you're wrong, but there's something wrong with you. You hear that enough, you believe it. And so then the person in the relationship feels as though there is something wrong with them. And without somebody explaining what's going on, then they're going to hold that on as an identity. And that's magnified if they grew up with a narcissistic or invalidating parent.
Wow. So for that person who's listening, who might feel that they're in that space, the person who's internalized that blame, felt that they were maybe a big contributor or the biggest contributor to the reason that this narcissistic individual is acting the way they are, is step one for them truly just first having awareness that this is even going on in the first place?
So I think that we're in an era where we feel things in our body before we feel things in our mind. So people will say, I am so wiped out after spending time with them. Like, I'm just not feeling well. Or once we give name to it, like, yeah, you don't feel psychologically safe, right? It's starting to give name to what people are feeling. But people will say, like, why am I dreading going? Like, why am I procrastinating going to their house? In a million different ways, we're telling ourselves, like, we don't like this relationship, right? We dread the weekends instead of welcoming the weekends, because on the weekends, it might mean you have to spend time with them, right? So all of those things are happening, but people don't quite understand it. Listen, I'm sure that the reason my YouTube channel has so many hits is that at 3 a.m, people are typing in, my spouse has no empathy and is super selfish and yells at me a lot. Bing, Dr. Romani's YouTube channel. I'm convinced of that because I don't think people have a name for it. They're just sort of, what is this?
What is
What's going on? And people also feel embarrassed and ashamed about taking that to their friends because they may not plan on leaving the relationship and they don't want to sort of create bad buzz about their partner or their family member to people who are close to them. Some people may get into therapy, but a lot of therapists don't know what this is. So they might keep focusing on, and I think this is one of the big mistakes of therapy, the therapists often focus, what's happening for you? How do you feel? What's your experience? Girl, I don't care about your experience. I need to talk to you about that mess you live with. That's how I do therapy.
Wow. I can say, as somebody in my audience, knows me, I can raise my hand and say I've been there at one point in time in my life, probably a couple of points in time in my life. And my story around that was not wanting to throw the word narcissist around because I thought it's not spiritual or whatever else. You've heard all this before. I've felt, this is a difficult personality. They have wounds that are driving them. I can see some of those wounds. I have to be stronger to manage that, which I know now isn't true, but I'm sure you've heard that from people.
Oh, and I'm sure many people listening to this still feel that way, because I think this is where the toxic positivity movement has done a lot of disservice to people in narcissistic relationships who said just that. Well, they're wounded, so I need to be better. I'm like, no, they're wounded. They need to take responsibility for their wounds. Like, no human being should ever be enlisted into the role of being another person's punching bag or pacifier. That is not how life works. And so and the fact of the matter is that the narcissistic person will gobble the other person up alive. They don't care. I think it's getting your head around that this person actually doesn't care. They may even be like, people say, but they're so smart. They're so smart. How could they not care? I'm like, why do you think smart and care have anything to do with each other? They are so smart and they don't care. That could be one sentence. And I think people struggle with that. They'll say, they're really good at this, or they're such a good cook. Like, good, they're a good cook and they don't care. Like, you can have this as one sentence. So people are coming up with these strange constructions, but I hear you when you say that they do have wounds. And people, there are many, the vast majority of wounded people out there do the work. They go and they face those demons, painful as it is. And that is something that narcissistic person could do. But again, it's a choice not to. And that's the hardest part of all of this. But I also know that not everyone can walk away. This isn't about walking away. That's not the only path forward. It's knowing what it is and knowing how to engage in it. So if somebody never listens to you, talks over you, has no empathy for you, has no interest in you, laughs at you and mocks you when you share an emotion, tells you you're ridiculous and gaslights you, then that really should be a wake-up call that you shouldn't be sharing anything with them. You want to talk to them about the weather? Do it. You want to talk to them about the Dodger game? Fine. But don't talk to them about anything else. I mean, it's the equivalent of having a really precious antique in your home and giving it to someone who's drunk and careless and is going to drop it on the ground.
In fact, that's one of the tips inside of your book, is this idea of, like, we all have some of those people in our lives, and maybe it's a boss, a coworker, a parent who's getting older, and different forms of narcissism might come out. It could be anything. It could be a partner. And in those situations, one of your big things is don't engage, or engage as minimal as possible. Yeah. You just kind of broke it down, but I think you have a framework for that, right?
I say, don't go deep. Don't defend, don't engage, don't explain, and don't personalize.
What types of relationships in our life, as an example, because I'm sure there's some relationship like that may not work with a spouse.
True.
Potentially, it will.
Absolutely, because you're not engaging, right? So when they say, why don't you ever take out the trash? And you're the one taking out the trash every single day, 3 times a day. Don't defend yourself and say that. They're looking for a fight. They're not looking for a quantitative breakdown of the number of times you take out the trash. They're not interested in the truth. They're interested in bashing you. So when they say, why don't you take out the trash more often? You're like, okay. And that's your answer. Instead of saying, but I take out the trash. I took the trash out 3 times yesterday. In fact, I know I took it out 3 times yesterday because it was raining. No, you don't explain. So many people want to say, but I want them to hear my point of view. They're not listening. They're not listening. And sometimes people say, but I want to defend myself. I said, if you want to, then do it. Then be prepared to be gaslighted. Be prepared to be talked over. Be prepared to be humiliated. So I'll say, do whatever you want, but then you need to be prepared for what's going to come back at you. And if you don't want those things to happen to you, then don't do it. So
there are these archetypes.
Okay, I'm going to stop it there. You can look up the videos of her online. She's got a whole lot of information if that's your jam and that's what you're interested in. But I want to get through the rest of this lecture. But I think that was a good insight to see the patient side. That is to say, the one that will come for therapy will be the one with the spouse or the person in their life who's behaving that way. So what this is a grid here is that the reason I put it up is because it's not uncommon for clinicians to confuse borderline personality disorder with bipolar disorder. And you may even hear the term border polar. And so this is almost always because the problem is you're always looking at the mood symptoms, but the mood is not the anchor. The trigger is the anchor. So you're really looking at borderline mood shifts. They're reactive. So someone looks like they're pulling away and the person then spirals minutes to hours, not days. So the emotional reactivity maps directly to the interpersonal sensitivity, especially the abandonment. So bipolar disorder, the mood shifts tend to follow circadian rhythms, not relational rhythms. So they intensify or stabilize with sleep, seasons, neurobiological cycles. The key is the duration. So in bipolar, the episodes will last days to weeks. You never see a 4-hour mania. In PTSD, which is also sometimes overlapping, in PTSD, mood shifts are anchored in trauma physiology, not relationships. So flashbacks, hyperarousal, emotional numbing, these are state dependent, not interpersonal triggers. So clinically, I don't ask the patient what mood they feel. I ask them what sets it off, and that will be the tell as to what disorder you're dealing with. And now let's talk about cluster C. So cluster C is about anxious, avoidant, and rigid. So cluster C, avoidant, attached, and anally retentive. Okay, that's the cluster C. They're avoidant, like in a or they might be over-attached in like a dependent personality disorder, or they may be anal retentive, like in obsessive compulsive personality disorder. And this will help you distinguish them during the assessment. So avoidant personality disorder will say things like, I want relationships, but I'm terrified of rejection, not lack of interest. It's fear-based in avoidant personality. Whereas in dependent personality, I can't function without someone making decisions for me. So the key trait there is submission in order to maintain the caregiving. With obsessive compulsive personality disorder, you'll see a lot of rules are more important than relationships. And so it's egosyntonic perfectionism, not anxiety-driven compulsions like in OCD. The patient will say things like, this is just how I do things, and other people are sloppy. That's OCPD. Cluster C is the anxious cluster. So these patients feel inadequate, they fear disapproval, and they may cling to others for safety. The avoidant personality person, they desperately want closeness, but rejection to them will feel catastrophic, and their avoidant behavior is a shield against humiliation, not a lack of desire. Whereas in dependent personality, these are patients who outsource their decision making to maintain attachment. Separation anxiety in adults is often misdiagnosed here. This is the true root. the dependent personality. So, and then an obsessive compulsive personality, this is the personality version of OCD, but without the distress. So it's egosyntonic. They believe their way is right, moral, efficient, even when it costs them relationships. Clinically, avoidant equals fear, dependent equals clingy, and OCPD equals control. So the predisposing factors here that we should look at, it's this blueprint of genetics. So some people come into the world wired with a higher baseline of anxiety, high inhibition, cautious temperament, sensory sensitivity. These are the kids who were easily overstimulated. They were slow to warm up, or they may be deeply attuned to adult emotional tone. And then you layer into this the environment. So if the home is critical, controlling, unpredictable, or emotionally barren, then the child learns one core rule, and that is I must avoid mistakes, conflict, and rejection to stay safe. And that's how you get these seeds of avoidant personality disorder and OCPD. So if the home is chaotic, or the caregivers are inconsistent, or overly protective, or infantilizing, then the child internalizes this dialogue of, I can't manage life alone. I need someone stronger to anchor me. Now you're seeing that architecture develop of the dependent personality disorder. So temperament interacts with parenting style. A shy, sensitive child with a harsh parent, that becomes avoidant. A fearful child with a smothering parent, that one becomes dependent. A perfectionist child with a rigid parent, that one's going to become OCPD. Now take a look here at the right column of the precipitating factors and fast forward all this to adulthood. What turns predisposing traits into a fully expressed pathology is stress. And the stress could be anything like a life transition, a new job, a breakup, a relocation. Anything that threatens that stability can awaken latent fears. So for avoidant or dependent personality structures, these transitions feel like cliffs, not steps. And social rejection or criticism can be a precipitant. So for avoidant personality, one negative interaction validates every catastrophic belief they've ever carried since childhood. See, I knew they'd reject me. And then for a dependent personality disorder, criticism pushes them deeper into reliance on the nearest safer adult. So stress-inducing situations like can trigger OCPD when they get triggered when the environment demands flexibility. Maybe they have a new supervisor, or there's shifting expectations, or there's some ambiguous task they need to accomplish. Their internal motto becomes, if I don't control everything, everything will fall apart. This is the person that can't take a day off. If I take a day off, that hospital is going to sink 3 feet into the ground if I don't show up today. Cluster C develops when fear becomes the operating system. It's first installed in childhood, and then it's activated by adult stressors. And what maintains it is avoidance and rigidity and that constant reassurance seeking. Now, what perpetuates this? Here's the trap door for cluster C. The very behaviors that people use to feel safe are the very ones that keeps this disorder alive. So in the avoidance of social interactions, the avoidant personality disorder feels like relief in the moment, but reinforces that core wound. I'm not good enough. People will judge me. Every avoided interaction is another deposit into that bank of inadequacy for them. Whereas in dependent personality, dependency tends to reinforce. So with dependent personality, the more someone else carries their responsibilities, their decision making, their reassurance, the stability, then the weaker the patient's independent muscles become. So this is a learned helplessness dressed up as support. It feels comforting, but it steals the autonomy. You will see this a lot in the adult failure to launch kid, the 25 to 30-year-old who can't do anything for themselves and still living in their parents' home. And the parents are still doing everything, including financing, feeding, clothing, sheltering, and paying for their cell phone bill still. The rigidity and perfectionism OCPD, you will see this is maintained by a closed loop system of rigidity and temporary control, leading to increased rigidity. So this person avoids uncertainty by tightening rules, and the rules become their identity. And this is what keeps relationships strained and growth impossible. So that's what's perpetuating this condition. Now, in the right column there, you'll see the protective factors, and we want to know what's going to break the cycle, essentially. Now, some therapeutic intervention, CBT is excellent for avoidant and dependent structures because this will directly challenge the core distortion. I'm inadequate. I can't cope. They'll reject me. Well, for OCPD, then DBT or CBT is where we want to do, because with the flexibility focus being key. So essentially, you're exposing the patient to good enough rather than perfection. Teaching somebody good enough is a major feat. Some supportive relationships here for cluster C can improve when the patient experiences relationships that are steady, accepting, and non-critical. And this rewires that expectation that rejection or humiliation is inevitable. And that's why they're in professional help, because this can certainly overwhelm the interpersonal relationships. Also, you want to help them develop coping skills, things like assertiveness training, learning self-soothing, increasing distress tolerance, some relaxation techniques to teach patients they can manage without avoidance, rigidity, or dependence. You need to embrace the suck, essentially. So the more mastery they build, the less they rely on the personality-driven defenses. So cluster C persists through avoidance, dependence, rigidity, but this can improve through things like gradual exposure, relational safety, and the development of some sort of internal coping capacity and a validation system. Cluster C is the anxiety-driven cluster. So pay attention here to these core features. Avoidant personality, I want connection, but I'm terrified you'll expose how inadequate I am. Okay? Dependent personality says, I can't cope without someone stronger than me. They have this excessive need to be taken care of, this difficulty in making decisions, this fear of separation. The loss of relationship triggers this rebound attachment, and any connection is better than being alone for the dependent personality. For the obsessive compulsive personality disorder, this is if I lose control, everything will fall apart, and they're preoccupied with rules, and that often will lead to inefficiency despite the high effort. And the project is never feeling good enough, and their reluctance to delegate, so they believe others will do it wrong, meaning not according to their rigid standards. The takeaway here essentially is this is cluster C is driven by fear, avoidance, fear rejection, dependence, fear abandonment, and the OCPD, they fear a loss of control. And here is OCD and OCPD side by side. And if there's one distinction you need to note, it's that clinicians will routinely miss this one. So slow down and imagine two different exam rooms. The OCD patient, the first patient walks in exhausted. They tell you, I know this doesn't make sense, but if I don't check the stove 14 times, I am terrified something awful will happen. So the thoughts are intrusive, they're unwanted, they're distressing. They have true obsessions, and their behaviors are repetitive, and they're aimed at reducing the anxiety. So they have true compulsions. They say things like, I hate this, it's ruining my life. OCD is ego dystonic. The symptoms feel alien, they're unwelcome, their functioning is impaired by the ritual. They spend over an hour a day consuming this thing. They're flexible in theory. They know the behavior is irrational, so good insight, but they feel compelled. And the treatment for them are things like exposure therapy and SSRIs. So OCD is fear plus ritual plus suffering that the patient recognizes. The second exam room is the OCPD patient. The next patient sits upright, frustrated, not anxious because someone has reorganized their files at work. They have no true obsessions, and they don't have intrusive thoughts. They don't have compulsions, only rules. order, perfection, control. Their rigidity comes from value, not fear. And for them, it's egosyntonic. So this is the right way. People should meet my standards. Functioning is impaired not by the ritual, but by the perfectionism and the inefficiency and the interpersonal conflicts they're causing. And they are inflexible, and the disruptions feel like an attack on their identity or their competence. So the goal for them is like CBT inflexibility with limited role for meds. OCPD is rules plus rigidity plus the belief that everyone else is the problem. Okay, so OCD is actually fundamentally an anxiety disorder, whereas OCPD is fundamentally a personality style. OCD will say these thoughts are torturing me. OCPD says if everyone would just do it my way, we would be fine. I'm not going to show you this video. You can pull this up. This is a video called Personality Disorders Crash Course. Write that down. You can look up the YouTube video for it. But across the three clusters, the common thread for all personality disorders is the mental rigidity. And these people are those who experience their thoughts are a very narrow set of coping strategies, and they keep using the same strategies long after they've stopped working. And so that mental rigidity versus flexible coping, think personality disorder, not bad behavior. And the goal is to build capacity, not control the world. So the work in therapy is not to erase the personality, it's to help add flexibility and more ways to think and feel. Capacity to tolerate distress, hold mixed feelings, stay in relationships, things like that. And you want them to step out of their victim story, because a lot of personality pathology is maintained by a victimhood narrative. So people always do this to me. No one ever, or everyone else is the problem. So if we validate real trauma and injustice, but we also gently shift the focus to what choices do you have now? What skills can you grow? So empowerment will beat the victimhood, hopefully, every time. And boundaries also, this word gets tossed around a lot. Boundaries are what I will do, not what you must do. So students and patients often misunderstand this concept of boundaries. A boundary is not, you can't talk to me that way. A boundary is, if you talk to me that way, I will end the conversation and leave. Boundaries describe our own behavior, not an attempt to micromanage someone else. So when you're sitting with a patient with a personality disorder, don't think, how do I get them to stop being like this? Instead, we're thinking, why are they rigid? What capacity is missing? And how can we, over time, help them grow the flexibility to live and love and work more freely? That's the heart of our personality disorder work. And there's no pill for that.